Our third lecture on central nervous system medications is going to deal with antidepressants, psychomotor stimulants, and lithium. Kind of seems like a hodgepodge, but they are related. You'll see as we go through. So your objectives for this section of the material is that you should be able to explain the mechanism of action of MAO inhibitors and describe their adverse effects and dietary restrictions. You should also be able to describe the mechanism of action of SSRIs, and probably know what SSRI stands for. Discuss the use of psychomotor stimulants, and you should be able to describe the clinical indications and common side effects of the medication called lithium. Now, we're going to start off a little bit talking about depression first. And there's really two different types of depression. The first is exogenous or reactive depression, and the second is that of major depressive disorder, abbreviated sometimes MDD. Now, depression that's caused by external factors, such as a death or loss of a job, is referred to as exogenous or reactive depression. This happens to any of us, any given day, any given time, and is usually short-lived. The second major type of depression is referred to as major depressive disorder. And major depressive disorder is more serious and usually requires both psychotherapy and drug treatment to manage it. This type of depression really originates from within the body and may not necessarily be associated with an easily recognizable cause, such as we talked about with the exogenous or the reactive depressions. So when we're talking about the medications that we're using treating depression, we're primarily talking about treating major depressive disorder. Those medications that are originating chemically from within the individual. Low levels of norepinephrine and or serotonin are associated with mental depression, while high levels of norepinephrine and or serotonin are linked to the problem of mania. Depression being that depressed state, and mania being that hyperexcitable state. Now, in some cases, there are alternating periods that go back and forth between that hyperexcitability and elation known as mania, and then that slowed state, inactive state called depression. Individuals who experience this type of alternating cycle between depression and mania are often referred to as being manic depressive, or another term for this condition is called a bipolar mood disorder. We're going to first take a look at depression and the medications that we use to treat it. So drugs that increase the level of norepinephrine or serotonin in the brain are useful in treating depression, and they are referred to as antidepressants, or mood elevators is an old term that they were referred to as. The major antidepressant drug classes include selective serotonin reuptake inhibitors, hence SSRIs, atypical selective serotonin reuptake inhibitors, and monoamine oxidase inhibitors, otherwise known as MAO inhibitors or MAOIs. So we're going to start with the selective serotonin reuptake inhibitors, which you may frequently hear me refer to as SSRIs because it's a lot easier to say. So SSRIs are a group of drugs that have a very selective action to block the reuptake of serotonin. So what happens is, serotonin is released and then the body absorbs it and gets rid of it. But if we block the reuptake of it, it increases the concentration of serotonin floating around in the blood. So we're preventing it from being reabsorbed, in essence, is what's happening. So more of it is staying around in the circulation longer. Now, you might recall that serotonin is that feel-good chemical. If you have ever experienced this, like dark chocolate will increase the levels of serotonin in your brain and make you feel good. That's why a lot of us, when we get down or get depressed, a boyfriend or a girlfriend or something breaks up with us, we end up going and filling our grocery carts with lots of stuff that has chocolate in it, because it makes us feel good, because it increased the amount of serotonin, temporarily at least, circulating in the body. So that's the action that's happening with these SSRIs. The same thing, they're increasing that amount of serotonin that's circulating around through the brain. And really, these have become the preferred therapy in the treatment of depression. So they're very effective medications. Now, there are adverse effects, as always, with any medication that come along with the SSRIs. They all pretty much cause GI problems such as nausea, diarrhea, dry mouth, and anorexia, that lack of appetite. They also have been associated with sexual dysfunction, particularly reduced sexual interest. And some of the other effects that you will see include headache, nervousness, insomnia, and tremors. Common SSRIs, and again, you should be familiar with some of these, specifically Lexapro, because Lexapro was one of the SSRIs on your drug summaries. Some of the other ones that you've probably heard of: Celexa, Prozac, Paxil, and Zoloft. I think I've seen commercials for all of those. And they all work by increasing the amount of serotonin by preventing the reuptake of serotonin by the body. The second group that we mentioned is that of atypical SSRIs. The atypical selective serotonin reuptake inhibitor also block the reuptake of serotonin, but they do affect other neurotransmitters and receptors in the body. They don't just affect the serotonin receptors. And as a result, they affect norepinephrine and dopamine in the body. So you can see effects of those. Some of the effects of those related to increasing dopamine and increasing norepinephrine in the body. The atypical SSRIs, again, work very similar, increasing that amount of serotonin floating around in the body. And you should be familiar with at least one of these, which is Cymbalta, because it was on your drug list. And you maybe have also heard of Effexor and or Wellbutrin. And Wellbutrin, it has been known to be used to help people with cessation of smoking. And again, because in addition to that making them feel good, it has some of those norepinephrine effects similar to that of nicotine. And so as a result, it can be used to substitute for that feeling of nicotine, and then you can just gradually wean someone down off of it, and hopefully they won't have their need for their smokes anymore. And the third type of antidepressant that we're going to talk about are called the monoamine oxidase inhibitors. So a little background about monoamine oxidase before we talk about the actual medications. What you can see is it ends in ASE, And if you recall from biology, anything ending in ASE is an enzyme. So monoamine oxidase is an enzyme that's found in most of your body cells, but it's particularly found in the adrenergic and serotonin nerve endings. Now, its normal function is to break down norepinephrine and serotonin into its metabolites so they can be excreted by the kidneys. So an MAO inhibitor, a monoamine oxidase inhibitor, monoamine oxidase itself, not the inhibitor, will prevent the buildup of excessive levels of norepinephrine and serotonin in the brain and other body tissue. So monoamine oxidase is going to break it down so we don't get too much of serotonin and norepinephrine building up in your body tissues. Well, in mental depression, we know that there's tends to be an abnormal decrease in the levels of brain norepinephrine and serotonin. So if you use drugs that inhibit or block MAO, you would then increase the amount of norepinephrine and serotonin circulating around. Consequently, MAO inhibitors permit the levels of norepinephrine and serotonin in the brain to increase. So, track that back. Monoamine oxidase breaks down serotonin. If we block monoamine oxidase, it's going to slow down the breakdown of norepinephrine and serotonin, and those levels are going to rise in the brain. Now, sounds all fine and dandy, except there are some things we do have to watch with monoamine oxidase inhibitors. Because if you recall, what we said is it's present in other body cells too, not just in those of the brain. And one of the main disadvantages of MAO inhibitor therapy is it has some dietary restrictions. Many foods contain a substance called tyramine, and tyramine is an amino acid that causes the release of norepinephrine. So when you inhibit MAO, it allows norepinephrine to build up, in which case tyramine may then be able to produce massive amounts of norepinephrine, which then can result in serious hypertensive crises, the blood pressure goes sky high, and or a CVA, a cerebral vascular accident, a stroke. So you got to watch on someone who has taking a monoamine oxidase inhibitors. They have to watch their diet. Foods that normally contain tyramine include fermented foods. So things such as wine and beer and like aged cheeses have tyramine in them. So someone who's on an MAO inhibitor needs to avoid these things. In addition, herring has it too, and I'm not quite sure why, but herring has a high amount of tyramine also. It's not really fermented, but it's got a high amount of tyramine. So beer, wine, herring, and a lot of aged cheeses need to be avoided by people who are taking these medications. In addition, there are certain sympathetic drugs, particularly used in the treatment of cold symptoms, that will interact with MAO inhibitors. Things like your decongestants would cause that same elevated norepinephrine effect. So people taking these medications should also be warned not to take decongestants, that they need to see their physician if they need something to control congestion. Common side effects or adverse effects from MAO inhibitors would include a dry mouth, urinary retention, inability to empty the bladder, constipation, hypotension, might see some weight gain, and they can also produce liver damage and cause some restlessness and seizures. So you do need to, in addition to monitoring diet, you do have to monitor blood levels and watch liver functions also on people who are taking these medications. Here are some examples: 3 monoamine oxidase inhibitors, Marplan, Nardil, and Parnate, that you may see people taking. But again, we tend to go to the, most physicians these days will tend to go to the SSRIs or the atypical SSRIs instead of the monoamine oxidase inhibitors, just because of the difficulty with the dietary restrictions. Now we're going to switch gears a little bit away from depression, just slightly, and we're going to talk about what are called psychomotor stimulants. And psychomotor stimulants are medications that include amphetamines and other closely related drugs. They're really not antidepressants, but they do kind of pick up the body and speed the body up. Amphetamines, they're also used, though, to treat narcolepsy, which is those people who tend to fall asleep spontaneously, and hyperkinesis in children who are hyperactive. So minimally useful as an antidepressant, but more so used for narcolepsy and for ADHD. And what happens is these amphetamines, what they do is they stimulate the central nervous system by increasing the activity of norepinephrine and dopamine in the brain. The amphetamines increase that neurotransmitter activity by several different mechanisms, but they act directly to stimulate the norepinephrine and dopamine receptors. They stimulate the release of norepinephrine and dopamine from nerve endings, and they also inhibit the reuptake of norepinephrine and dopamine, similar to what you saw with serotonin in the SSRIs. So they work in 3 different ways. The disadvantage that they have, though, is that they do have a problem with drug tolerance, meaning someone over time needs to take more and more, and drug dependence. People become dependent on amphetamines. And, as most of you know them as speed, they're highly marketable as street drugs and are abused very highly and marketed illegally. Now, the psychomotor stimulants, as we said, do increase the activity of the sympathetic nervous system. So, some of the side effects that we frequently will see with them are that of dry mouth. We will see the rapid heartbeat, because remember, they're increasing that fight or flight response. We'll see increased blood pressure, restlessness, and insomnia. And in many cases, when we're treating ADHD, that's one of the big complaints that we get from kids, is that then they have trouble sleeping. Even though they're able to concentrate more, now they're having trouble sleeping at night. Frequently, by changing the medication or by altering the dosage or what time of day the dosage is taken, we can manage a lot of those symptoms. Common example of a psychomotor stimulant, many of you have heard of it, is Ritalin. And this is exactly what Ritalin is and how it works for our population of people who have ADHD. Then our last category of medication, or last medication we're going to deal with in this group, is that of lithium. And lithium is used to treat the manic phase of the bipolar mood disorder. So it's usually used in combination with an antidepressant to manage manic depression or that bipolar disorder. Again, it treats the manic part, it's not treating the depressive part. And it works because lithium is a salt. And lithium and sodium exist in body fluids like charged particles. So it's very similar in nature to that of the ion sodium. However, where sodium is normally required for conduction of nerve impulses, lithium does just the opposite. It interferes with nerve impulses. So as a result, lithium has the opposing effect on nerve conduction as salt does. Now, what happens is when we put lithium in the body, I like to paint it this way. Salt is to broccoli as lithium is to chocolate. Okay? If the cells have their choice between sodium and lithium, broccoli and chocolate, they're going to take the chocolate more often than not. So what happens is when we put lots of lithium ions in the body, the cells tend to grab onto the lithium and forget about the sodium. And as a result, that's where you start seeing the decrease in nerve conduction, the decrease in excitability. And that's exactly what happens. We're tricking the body into taking up lithium instead of taking up sodium, and therefore decreasing conduction across the neural pathways. Now, there are side effects of lithium even at the therapeutic doses that we need to watch out for. Most patients experience some nausea or tremors that usually disappear once they get adjusted to the medication. But when you start to see an overdose or too much of the medication, you will start to see vomiting, diarrhea, drowsiness, a loss of balance, and ringing in the ears, and frequent urination. So when you start to see those things, now we're talking our dosages or blood levels are getting too high. It can also go very quickly to a toxic level. And when you see toxicity, you can see heart damage and kidney damage, which can lead to cardiac arrhythmias and or nephritis. So it's very important that blood levels are monitored on lithium, as well as patients are aware of the symptoms that they can have if their body starts to get too much of the lithium salt in it and starts substituting too much sodium or too much lithium for sodium. Now, the one thing that does help, though, is, believe it or not, because they are so closely linked together, sodium is necessary to properly get rid of lithium. So you have to have plenty of salt in the body, even though the body's not using it. So if someone has a decreased sodium intake, then they can retain lithium and they can become toxic. So we encourage people on lithium to eat things that have salt in them. And I've even had patients who we've gone and have prescribed sodium tablets for, so that we're sure that they are getting enough salt into their body. And occasionally I have some of those who, will manage their lithium pretty well, that, they have salt tablets. If they start getting diarrhea or those drowsiness, they know to start taking some extra salt, and they can take care of it pretty quickly that way. So with that, we then wrap up our series of medications that dealt primarily with depression, and then we threw in the psychomotor stimulants in there, slightly used for depression, but more often than not used for like our ADHD patients.